Good morning. Yeah, so I'm really happy for the invitation, and thanks, Mr. Chair, and all in attendance. So as Prof. Kaima has mentioned, I'm my background, I'm a medical doctor, and I'm happy to see Dr. Kiapi here, who was one of my mentors in Nakuru PGH, and of course, all the rest that are my teachers in the past. So I work with the Clinton Health Access Initiative as the regional technical advisor for health financing, where we're leading conversations with different governments around how to make health financing reforms. But the most interesting thing is some of the countries are grappling with this question from different perspectives. So some of them are still at the point of the decisions on are we talking about hemodialysis, peritoneal dialysis? How do we position that within the benefit packages? Then there are conversations around what investments can be made, in the overall to just improve renal care. So we're going to talk about that as well. But this session really is how do we, as practitioners in the room, engage policymakers with, that step out of the science and get into the politics of health. And we'll start with the question that was, Dr. Cheptinga asked, how do you engage, especially when you go to the transplant, to actually make sense to them and run down the numbers? So that's what I'm going to talk about. Yeah, so, but to go there, what becomes important is stepping back and looking at, there's a kidney, but the kidney is in a person, and the person exists within a system. And in this system, there are quite a lot of other players, and it could be at a country level, but most importantly, at a global level. And at a global level, there are policy discussions that people are driving that influence even at the local level what happens. So at the global level, there's a drive to achieve UHC, as envisioned by this, Sustainable Development Goals. Then, of course, one of the targets that was set was how do we move, towards improving, reducing mortality that is related to non-communicable diseases. So that's at the global level. But at the national level, there are commitments that we must, hold some of the people who make the commitments, accountable to it. So there's a UHC, and by that, I highlighted a couple of things, that there is the element of all Kenyans, there's the element of access, there's the element of quality, and finally, financial hardship. And I'm going to highlight this financial hardship because it addresses the question that Dr. Cheptinga asked. How are we covering the kidney to ensure that patients do not get into financial hardship of, in terms of accessing care? So one thing that stands out in all this is that the healthcare needs are infinite and the resources are finite. So what does that mean? That there are newer interventions. I think we've had this, Dr. Cheptinga, as you're presenting today. There are quite a couple of interventions that there are options, but in this they are changing priorities because there is a kidney, but there are other organs as well that need this kind of support. But the other point is the patient's expectations are also rising. So in terms of the needs. But, this fits into a health system, but we also have to know that, resources are finite. There's the other element that we have to keep on talking about, that our aspiration is let's have as much money as possible within the health sector, but how can we stretch that shilling to get more health? So that means what kind of thoughts can we run in our heads that can get within the existing resources to get as much as we can? Because in a health system, unlike any other financing modalities or banks, we are not in the business of saving money. We're in the business of buying lives every day. And by life, it simply means for every amount of money that we're spending, we must buy as much as we can using the interventions that do exist. So these are some of the most recent policy conversations that are going on. I think some of them as old as yesterday, some as 2 years ago. And I know, so Dr. Cheptinga, right down here is an article, an op-ed I made to the Business Daily, making the argument that you're talking about around how can NHIF move towards improving kidney in terms of kidney transplant. So I make a couple of arguments that I'm going to talk about later. But a couple of days ago, they ran their numbers and said, kidney, that dialysis now is for the third in terms of their costs drivers of care. That's after major surgeries and inpatient care. So that's one of the elements that they brought out a couple of days ago. And yesterday, one of the elements that came out, they want to reduce the reimbursements they have for dialysis from, I think, the current 9,500 to 6,000, which is an interesting conversation that is tied to this, but happy to talk about that more. But I just thought I highlight this to also know that there are people talking about the kidney on the table and how we're positioning ourselves to be part of that conversation, to influence some of these bits and pieces that we're talking about, that we look at the patient, but then we step back and sit on the table and see how well to address the patient that is geared towards addressing the kidney as well. So what about, talking more about dialysis, what is the evidence out there in terms of spend? So, if you look at in most countries, in 90 countries, a study done recently showed that, despite the fact that there is a lot of focus to help, to provide care through dialysis, it only covers 29% of the population need. But if we were to cover fully using dialysis, then dialysis alone will account for from between 15 to 55% of the healthcare expenditure. So that means all the resources available for health, you'll have as much as 55% being spent on dialysis if you are to cover 100% across the 90 countries or on average. So just figure that out as we have a conversation around how do we definitively have a conversation that looks at addressing some of the issues that Dr. Cheptinga raised. So this is a quick rundown of figures that we in the article that I mentioned earlier that we ran. So we didn't factor in inflation, and there are a couple of assumptions that we made. And just to bring, quick ballpark figures without much inclusion, especially around, the tests, because we ran assumptions that there are certain tests that we need to do, especially when you're dealing with dialysis. So it will be interesting that this could actually be higher if we included issues around tests. And I'm going to talk about the other indirect costs as well. So looking at with an assumption that we're dealing with 3 weekly sessions at 9.5, that's what NHF pays, of course, ignoring the fact that they're trying to lower that. So that gives you an estimated figure, and this is a lower end without factoring in the tests, which I'm sure as a nephrologist, you know how many other tests you've got to do. Of course, with an assumption that this patient does not have an AV underlying, mechanisms, because most of them are diabetics, they're hypertensive, so the other costs also that come alongside that. So we have about, 7.4. Then, on the kidney transplant, the figures we were working with, on the low estimates was on the public hospitals, I think having MTRH in mind, and the upper estimates looking at high, at the private hospitals on average. So, and if you look at the first year, we pumped up based on what you mentioned on induction. So there's a higher spend on induction. So coming down to that figure. So happy to talk through this in terms of what reflections are there, but it clearly shows there could be a case to make, but actually it gets more complicated because NHF pays for the surgery, but does not pay for the medication. I think that's the other point that came up. So we're going to talk about that shortly around what are the implications and how we can address the question. So those are the direct costs, but something that we need to keep in mind that there are indirect costs that the patient has to bear. Number one is travel costs. So if I'm to come to the dialysis center every day, no, every 3 days, let's imagine an average of 500 shillings to and fro to the dialysis center. That's 500 per day, 3 days. That's so that per week is 1,500. If you do that times 52 weeks, then you look at the spend per annum. The other bit that we also factored in the analysis is the human capital loss. So if I have to go for dialysis every 3 days a week, it means I'm missing work. So if I'm missing work, if you use the minimum wage currently at about 15,000, so that means every week I'm missing 45,000 worth of work, but going for dialysis every week all through that period. The other point that we also factored in was the opportunity costs within the health system. By dedicating, all this number of nurses to dialysis, it means there are less nurses left to take care of other healthcare needs that the population has. So there are a couple of other considerations to look at, especially when you're making this case, that by keeping the patient, there are also other aspects that are indirect to the system and especially to the society. So what are some of the things that are happening right now in terms of how we can talk about it? So one thing that we have to also appreciate that the coverage for the surgery is a win, is a win that we must also recognize to make sure that we keep that going and how best we shape that conversation as well. But something that we also have to keep in mind is the failure to cover the post-transplant medication itself. It's something that we should really think through and see how well to shape that conversation. Because what happens is once you don't cover it and then you lose the kidney, then it negates everything, all the gains that you made earlier. And it even becomes worse because then once it fails, you have to go back to dialysis. So NHF paid for the surgery. It failed to sustain the kidney. Then, you had a failure. So it means you have to go back to dialysis, which NHF pays again, and more than what will have paid for the transplant, okay? The most interesting thing is you might actually need a second transplant, which NHF will pay for. Okay, so if you look at the cost, what it takes to actually go in and out, it accounts for quite a significant amount of money. The third one, and which becomes very important, especially an advocacy conversation, is also recognizing kidneys are a scarce resource. And so we should work towards making sure that one, we are on the table to talk about how best then can we drive availability of the organs. And secondly, how best can we shape to make sure that all policies are geared towards preserving this rare resource. And it's about someone has donated, how can we make sure that it survives? Or how can we get people understand organ donation in general and how we can shape that conversation as well. So what can Kenya Renal Association do? One of the things that we just have to also be on the forefront is what mechanisms we're establishing to capture data that enables to give enough information or longitudinally such that we're able to have these conversations around the outcomes, comparatively giving some information around outcomes, how that will be helpful, because I think we need to demonstrate a compelling evidence, even though there is, but I think a lot of people need to see more around how this could shape, in terms of improved livelihoods. And again, as I mentioned earlier, the core mandate of any health system is improved health outcomes. So whatever we do, it doesn't really matter if we do not improve health outcomes. And the second one is, how do we advocate and be on the table with the MOH and the other payers? And some of these payers that I'm talking about is not only NHIF. I think we should also engage the other private payers. The reason why I'm mentioning this, because currently if you look at the amount of the ballpark figure around what NHF runs is almost equal to what the private insurers run. NHF currently has, every year has in their purse about 60 billion Kenya shillings. And, the private insurers have almost the same, slightly, maybe about 50 billion in their purse. So we are talking about an amount of over 100 billion in the health sector held by the insurers, and how, as kidney specialists, we position this is really about being on the table, defining what gives more value to the patient, but at the same time, trying to demonstrate them long-term gains. Because as a private insurer, one of the things that I need to see is I can front load this amount, but then in the long term, have it lowered, or I can provide good care at the beginning, then that provides savings in the coming years. Because what they're in the business of, especially as an insurer, is having predictable costs, and all through see a trend of that going down. So happy to maybe address questions when we are getting to that time of questions, but I think that's all I had for us today. Thank you.
Thank you so much. I think that is a real good highlighter. Thanks.
Thanks, Dr. Our next speaker is known to many of us, Dr. Ngigi. Oh, yes. So Dr. Ngigi is a consultant physician and nephrologist, and immediate former in charge of renal medicine at KNH, and as he exits that position is the incoming chairman of Kenya Renal Association, and the chair of the conference as well. He's going to talk about COVID-19 pandemic and how it has affected transplantation globally. Welcome, Dr. Ngigi.
Thank you very much for that very good introduction. First and foremost, I want to thank you people for availing yourself this morning. You can see the group is increasing. I want to also appreciate ISN for having educated me this far, and of course for the contribution ISN has given to us as Kenya Renal Association. I did my nephrology at the Stellenbosch University and Tigerberg Teaching Hospital with Matthew and others, and Alazin Davids and Rafik Musa, persons I respect so much. And this morning, I want to engage you briefly on what has happened to us during the COVID-19 pandemic and the influence this has had within the transplant landscape. I've got no interest to declare. The company that brought me here, sponsored me here, has no interest in transplantation whatsoever. So I'm free. We know much more now on COVID-19 than we did last year but one. I will not go to the details because we know the science of COVID-19. But I want you to appreciate that acute kidney injury is at the center of this pandemic, and patients who get acute kidney injury within this COVID-19 story will often have poor outcomes, and this poor outcome is related to the need for vasopressors, mechanical ventilation, and often they will die. And that patients with CKD, end-stage kidney disease, transplantation, and indeed those who have got glomerular diseases, perhaps because of the treatments they receive, may be at increased risk for infection and associated morbidity and mortality. Now, this slide, I saw it with Professor Mark Rigel, and of course, is a common slide for those who have been reading. It really tells you the various pathophysiological mechanisms under which kidneys suffer in COVID-19. Center to this, of course, is a cytokine storm. Patients or kidneys getting acute kidney injury from ATN, interstitial nephritis. And interestingly, we have observed, or it's in literature, that persons who get various glomerulonephropathies and that high-risk APOL1 gene is again one of the things that's being mentioned. And like Jonathan Walla said yesterday, in days to come, we may see a lot of CKD related to this COVID-19. Now, when COVID-19 came calling, we know what happened. And this acute kidney injury treatment, of course, was in a mess. A lot of risks, a lot of challenges, issues to do with access to care, resources, drugs, and all that. And the world learned how to go around this. And that's why perhaps I'd say that the outcomes are more predictable than they were last year but one. But then we understand much more on acute kidney injury, but we don't know too much on CKD. The only thing we know for real is that people who have got acute CKD are likely to get chronic kidney. I mean, people who have got chronic kidney disease are likely to get AKI related to COVID-19. Now, the data on or among patients CKD and end-stage kidney disease is really scarce. But again, like I said earlier, these long COVID survivors or the long COVID patients are going to have huge risks of progression of their disease. And we must always remember that kidney injury is going to be common acutely and chronically, and we must aggressively look out for kidney disease in these persons. Work has been done out there, and this literature is now available. I'm sharing with you a slide which demonstrates or which shows a study which looked at outcomes among patients hospitalized with COVID-19 who either had CKD and end-stage disease and COVID, and those ones who are normal. In these patients, one can clearly see that the normal patients, or those ones who didn't have CKD, being as reference, were obviously advantaged. But when you come to patients who had CKD, then one sees something very interesting. Whereas many of us have been thinking that people who have got end-stage kidney disease and on dialysis are likely to die, then this study reports something different. And it says that patients with end-stage kidney disease appeared in this study to have better outcomes than those with non-dialysis CKD. Of course, there are issues to argue here, but this study, of course, is not one that one can quote and say it's generalized, but it's something for us to think about. Perhaps, again, one would imagine that patients who have got end-stage kidney disease may have maybe less cytokine storm and may be able to then survive through this. And this is observed by the fact that they had lower C-reactive protein levels at admission, one of the markers of inflammation. This is just one of the things to think about. We may not have our own local data, but again, as individuals, we have participated in managing patients CKD and COVID, and we know our feelings about this, but this tells you more the controversies that exist on this. Now, what about in kidney transplantation? What have we learned? One of the things that we now know is that presentation of COVID-19 in transplant recipients appears to be similar to that in patients who are not immunosuppressed. Small studies again here and there, but we know that the mortality rate is between 20 and 30%. But again, it's still difficult to conclude whether kidney transplant recipients are at an increased risk of death from COVID-19. And again, personally, I've participated in managing quite a number of patients who have had transplant in COVID-19, and many of them have survived. Again, looking into the literature, this very interesting article in JASN tells us that these patients who are likely to die are the ones who have various comorbidities, and asthma, chronic pulmonary disease, among others, have been shown to be independent risks for death among patients who have got COVID-19 and have been post-transplanted. Now, we looked at our literature at Kenyatta National Hospital, and we are still ongoing into understanding our patients. Of the 300 patients we have been following up, 24 patients, unfortunately, got COVID-19. The mean age for that is, as you can see there, 48 years. The median is around 48, with the other statistics as shown there. Again, doesn't deviate much from what we know, that males were more likely to get COVID-19. Only 3 patients died. This is not very impressive data in terms of size and numbers, and we didn't do sub-analysis because of the amount of data. But again, this is still works in progress, and we shall be reporting to you our observations. But the message is we are still having our patients getting COVID. Males are more likely to come to us, but the mortality may not be as high, and the fear that we had before may not be as warranted. Now, because of these fears and deaths and all that, the world then sat back and said, do we transplant these persons or not? But then an advisory came in, and this is what is now being practiced, that there is need to be a balance between the benefit of transplantation for individual patients and the risks of nosocomial COVID-19 spread for both recipient and donor. In other words, we must not expose these patients to COVID-19. They must not come to hospitals and get COVID-19 in hospitals. Again, there has been this push for individualized decision based on scoring tools. Now we have got tools that can assist you to score and assess the benefit of transplantation against not transplanting. And these are tools that perhaps we want to look into so that we make rational decisions on transplantation. Of course, the general measures of transplantation, the general measures of trying to contain COVID-19 will apply. But the fact that we need to social distance and all that has pushed deliberately our patients away. We don't want them to come, we want them to stay. And this, among others, has seen a reduction of transplantation rates in the world. Telemedicine, like the one we have been practicing at KNH, robustly, both video and telephonically has been very helpful, and most of the world has embraced that right now. And this, again, has been very helpful. But again, there has been considerable barriers to telehealth access, and particularly for the low middle income economies, this has not been available, and this has brought out of inequities to transplantation. But when clinically appropriate, this is a way to go. Defer and don't do a lot of laboratory testings, or those which will make your patient come. And for renal biopsy, I don't think there's a time you want to do a lot of renal biopsies. But again, this is not the time to even think about rejection, which would make you want to do renal biopsy, because management of this can be very, very tricky at this time. Management of COVID-19 protocols have changed over time. A lot of diversity is here and there, and individualization of care. But importantly is that the world has learned that this story of immunosuppression is not the way we used to know it, and we can comfortably now manipulate immunosuppression. Sometimes we even go off completely immunosuppression, and for the number of patients I've taken care of, sometimes they have even come out better in terms of their renal function than they were before, perhaps because of the robust use of steroids and stuff like that. So the point is, we are not as fearful as we were when joking around with this immunosuppression, because at the end of the time, we want the patients to live. Now, generally, within all this matrix, many people will reduce immunosuppression, the net immunosuppression, importantly targeting the antimetabolites, and again, depending on the disease situation, come down on the CNI. For another issue in management is about now whether to treat patients as outpatients or inpatients. Of course, these are decisions that are made within programs. Now, the European Association of Urology, in its contribution towards management of transplantation in the world, has come up with risk management guidelines. But again, central to this again is the abilities of institutions to handle transplantation. They have come up with 3 priority groups: the low priority patients who will be deferred, or you can postpone transplantation for at least 6 months, provided there is no harm. Then you have got the high priority and emergency category who needs transplantation. And in between, you have got the intermediate category. Now, this one, coupled with the simulated tools I mentioned earlier, would be a better guide for people, practitioners of transplantation, to think about in trying to offer transplantation. So basically, we have observed a reduced uptake of transplantation all over the world. And this has been because of scarcity of hospital resources, limited testing abilities and capacities. Some institutions still cannot do the SARS-CoV-2 PCR testings. We do not understand. Sometimes you have got problems with the sensitivities. Many other times we wanted to do a transplant, then we tested the patient. Yesterday, the patient was negative. Today, we test the patient is positive. All these uncertainties has contributed into us slowing down. And of course, those outcome concerns I mentioned earlier of who will live and who will die. Then comes in the ethical issues of transplantation. Again, this has been challenging, but have not yet been addressed. For example, how ethical is it to keep someone on the list because they live with people who are at high risk for spreading COVID-19? It means that persons who live in settlement areas because of the crowding and all that may be pushed off, and then the most affluent people who are able to stay 1 acre away from each other will get transplantation. These are ethical issues. Is it ethical for hospitals to suppress transplant volumes to maintain ICU beds in anticipation for additional future of COVID-19 resource burden? Because often with transplant patients, they get very sick, they go to ICU, they block a bed. So people then would say, oh, wait a minute, transplantation is not that serious. So how ethical is that? How ethical is that we deny patient transplantation when you know that it's life-saving so that we can save others? So these are ethical issues that need to be tackled, and the world is still out there looking for solutions for this. Stock and others have recently commented in Transplantation Journal, and this is what they are saying. Programmatic decisions about transplantation will weigh more heavily on distributive justice, beneficence and non-maleficence than respect for autonomy. Who benefits more and others without harming them is what we are saying. Ethical issues here, which needs to be addressed, and indeed very, very important. In conclusion, ladies and gentlemen, COVID-19 has adversely affected the landscape of global transplantation, and there's been a need to change protocols during the pandemic. Equity and access to kidney transplantation has been influenced by economics and has adversely affected the low middle income countries like ourselves. Vaccine equity has been a major challenge. We've been pushing our transplant patients must get vaccines and all that, and we all know the story of vaccines. The influence of the pandemic in ethical and unethical practice is a thing we need to every day consider. These challenges exist and need to be addressed. And as you know, transplantation science is evolving and it's still works in progress, and let's see what happens. Asanteni sana. Thank you very much.